Welcome back to our second session of online seminar on prenatal and preimplantation genetic diagnosis, hosted by Changhua Christian Hospital. This is Meng-Shin Shiao. I'm the Assistant Dean for International Relations, Faculty of Medicine, Ramathibodi Hospital, Mahidol University. And I believe everyone enjoyed our discussions in the first session 2 weeks ago. And I do wish that we will have more fruitful discussions again today. So like last time, we will have a panel discussion at the end of the 3 talks. And it is also welcome to leave any of your questions at the chat box anytime you want during the talks. And we will gather all the questions together after the 3 talks. Okay. So without further ado, let us welcome Mr. Wei-Ming Hsu, Acting Representative of Taipei Economic and Cultural Office in Thailand, to give us opening remarks.
Dear Dr. Nina Kao, CEO of Overseas Medical Mission Center of Changhua Christian Hospital, Professor Adithep, Head of the Department of Obstetrics and Gynecology at Ramathibodi Hospital of Thailand, all speakers and participants of this online seminar, ladies and gentlemen, good day. I am Herbert Hsu, the acting representative of Taipei Economic and Cultural Office in Thailand. On behalf of the Taipei Economic and Cultural Office in Thailand, I would like to recognize Changhua Christian Hospital of Taiwan for its hard working in promoting medical cooperation between Taiwan and Thailand, especially in the time of COVID-19 pandemic. I'm really looking forward to seeing such events organized in physical mode in the near future. Now I would also like to express my sincere thanks to Changhua Christian Hospital of Taiwan, Faculty of Medicine, Ramathibodi Hospital, and Faculty of Medicine, Siriraj Hospital, for jointly organizing today's event. And I wish today's online seminar very fruitful and successful. Thank you.
Thank you, Mr. Hsu. Next, we would like to invite Assistant Professor Adithep Jaovisidha from Faculty of Medicine, Ramathibodi Hospital. She is the head of the Department of OB/GYN, to give us an opening remark.
The organizer, ladies and gentlemen, my name is Dr. Adithep Jaovisidha, Head of Obstetrics and Gynecology Department, Ramathibodi Hospital, Bangkok, Thailand. It gives me a great pleasure to welcome all of you and address the opening ceremony of the online seminar on prenatal and preimplantation genetic diagnosis. As is well known, prenatal diagnosis aims at early, rapid, and accurate diagnosis, as well as at the improvement of management of normal and complicated pregnancies. Recent advancement in this area has brought a state-of-the-art alternative to those conventional methods, which is non-invasive for couples at risk of transmitting a genetic disease of their child. The technique is known as non-invasive prenatal testing, which has revolutionized the approach to prenatal diagnosis and to date is the most superior screening method for the common autosomal aneuploidies. This screening is having a significant population-wide impact on the uptake of prenatal screening, although further clinical validation studies are needed. These tests bring advantage through providing a higher diagnostic yield without risk of miscarriage. Another recent development in the area of pre-implantation genetic diagnosis, which has proven invaluable for very early prenatal diagnosis. This particular technique combines assisted reproductive technology with molecular genetic and cytogenetic to allow the identification of abnormality in embryo prior to implantation. The pre-implantation genetic diagnosis has been a topic of debate at many levels, both nationally and internationally. Nowadays, pre-implantation genetic diagnosis has been widely adopted throughout the world for various indication and being proven to substantially decrease the eventual risk of passing a genetic undesired condition of the offspring. The online seminar today is packed with a number of advanced and challenging topics regarding prenatal screening tests and conditions for which pre-implantation genetic diagnosis is useful. This online seminar has been designed to be practical and encourage participant and scholarly dialogue among practitioners. Our seminar features experts from Changhua Christian Hospital of Chinese Taipei, Faculty of Medicine, Ramathibodi Hospital, and Faculty of Medicine, Siriraj Hospital, Mahidol University of Thailand. These forums will not only advance the participant understanding of the technical aspect of the field, but also constitute a great opportunity to share experiences and discuss the legal and ethical challenge of this genetic screening technique. As a token of my appreciation, I would like to take this opportunity to express my sincere thanks to the organizer and in particular our honorable speaker. All the speakers are highly experienced practitioners and prominent researchers in the field of prenatal screening. We truly appreciate your dedication. I hope that this program will ultimately contribute to leading the field forward and ensuring the accuracy and safety of the screening in clinical setting. At this point, it is an opportune time for me to declare the opening of the online seminar on prenatal and pre-implantation genetic diagnosis. I hope that our seminar is an enriching experience for you all, and I wish you a pleasant and fruitful time in our seminar. I thank you for your interest and participation. Thank you very much.
Next, we would like to invite our beloved Dr. Nina. She will represent Changhua Christian Hospital to deliver the opening remarks for us.
Sawadika. Good afternoon, ladies and gentlemen. It's my great pleasure to join today's seminar. So I'm Nina, the Director of Overseas Medical Mission Center of Changhua Christian Hospital. Also, I'm one of the co-organizers of today's online seminar. So first of all, I would like to thank our moderator, Meng-Shin, same as the last session on May 16, to assist us to invite speakers from Ramathibodi Hospital and Siriraj Hospital of Thailand to share the experience about their prenatal genetic diagnosis today. So Changhua Christian Hospital is a medical center in central Taiwan with 9 branches and cooperation hospitals. We have very strong IVF team and the prenatal genetic diagnosis team, so they can work together to detect the genetic diseases in the early stage of pregnancy. I know that in Thailand, the faculty of Mahidol University, Ramathibodi Hospital, and Siriraj Hospital are both the top of medical center in Thailand with excellent research. So it is very our great honor to invite experts from Taiwan and Thailand to share their latest research with us today. So on behalf of the organizer, Changhua Christian Hospital, I would like to thank Professor Adithep, the head of the OBGYN department of Ramathibodi Hospital, and the acting representative of Taipei Economic and Cultural Office to support our events. Also, thanks to our 3 speakers from Changhua Christian Hospital, Dr. Chen, Rama Hospital, Dr. Chonthicha, and Siriraj Hospital, Dr. Tuangsit. Special thanks, Dr. Tuangsit, because he joined us in session 1 and also today's session. Thank you so much. So thanks to take your time to join us today. So finally, I sincerely wish today's seminar will be successful and you will get innovate insight. Thank you so much. Meng-Shin, the floor is yours.
Okay, so we should start our 3 special talks today. The first one is from Dr. Tuangsit Wataganara. He told us about ultrasound, how ultrasound can help us for the prenatal diagnosis last time. And today he will talk about prenatal cell-free DNA screening for trisomies 21, 18, and 13, and also 22q11.2 deletion. Let's welcome Dr. Tuangsit.
Hello, everyone. My name is Tuangsit Wataganara. I am a maternal-fetal medicine specialist I want to thank the organizing committee for allowing me to share our experiences of using the NIPT in our practices. Just so you know that we do have our own in-house NIPT, so that makes a big difference in how we implement the test into our patients at Siriraj Hospital. But first of all, the technologies of the NIPT can be divided into the sequencing and non-sequencing technologies. For the sequencing technologies, it can be divided into either the ion proton, which is like an open platform for any one to develop without the licensing fees, whereas the Illumina platform actually it has to be done through a specific manufacturers. The novel platforms actually can bypass the DNA sequencing steps, and it is claimed to reduce the turnaround time. Although that may not be true nowadays because the sequencing technologies has advanced quite a lot, so the turnaround time for the sequencing platforms can be quite fast as well. So we are talking about the NIPT as a screening tool for the aneuploidies, but we do not have to forget that the fetal, the cell-free fetal DNAs, analysis in the maternal blood actually stem from the in attempt of a detection of the fetal sex, the RH status, and the single gene diseases. Right. So we need to know that the source of the cell-free fetal DNA in maternal circulation, 99% comes from the apoptotic trophoblast, meaning it comes from the placenta, not the fetus itself. Only less than 1% coming from the lysis of the lysis of the red blood cells of the fetuses that traffic into the maternal system. The fetal fraction is the ratio between the fetal-derived nucleic acid as per the maternal background DNA. The truth is that the fetal fraction has slowly increased over gestational period. So if your NIPT fail from low fetal fraction, the redraw can actually settle only about 60% at the time. So because it's about the activity of the apoptosis, it's not about the enlargement of the placental volume. So when we compare the first trimester screening, which is the combination of the Newport translucency and the serum biomarkers like the PAP-A and free beta HCG. So for the first trimester screening, we are aiming to for the population screening. So the performance of this test really rely on the detection rate and the false positive. Whereas the performance of the NIPT is a bit more of an individual performance. So we are talking about the positive and the negative predictive value. Positive predictive value means that what is the real positive rate after the positive result. So I just want to show you why this is so important, because the rationale of the PPV is that it relies heavily on the prevalence of the disease in the screened population or the screened individual. So the higher the prevalence of that disease, in this case Down syndrome in advanced age pregnant women, the higher performance the NIPT will be. According to a paper published by Diana Bianchi back in New England Journal, the performance, the positive predictive value of the NIPT for trisomy 21 could be as low as 50%, 50% in young age individuals, as compared to 80 to 90% if we test it in the advanced age women. So you should pick the person that you would screen appropriately. So the traditionally, there are three approaches for implementing the NIPT in our practice. The universal screening, which is to screen everyone, and then which may not be so, in the past we were so resisting in offering the NIPT like at will of the patients, because apparently if you do it in the low risk group, the performance isn't that good. So we used to be implementing the NIPT on the contingent model or the reflex DNA model, meaning that we used the first trimester screening to everyone, and then only those with the intermediate risk estimate, about 1 in 100 to 1 in 2,000 will be called back to get an NIPT. This approach actually has a downside because it means that the patient will get 2 risk estimates, one from the first trimester screening and the other one from the NIPT, which is quite odd. So another approach is that the reflex approach is that you draw the blood, additional amount of blood into the stretch tube, which can preserve the DNA. And if the first trimester screening came out as intermediate risk, that tube will be taken out from the refrigerator and to process with an NIPT. In this case, the patient will not get a phone call, and she will get only 1 risk estimate that will help her decide if she wants to go for the invasive prenatal testing. Okay, so again, this diagram is just to reiterate that the first trimester screening is for the population, and the NIPT is pretty much for the individual performance. So the major determination of the performance of the NIPT is undeniably the fetal fraction. Unfortunately, the fetal fractions that are carried out in each and every private providers are different in the assays. Either it's bisulfite conversion, either it's SNPs sequencing, it's size fractionation. So when there is no standardization, it's very difficult to compare that. Okay, what would be the lowest limit of detection, and which platform can detect or can yield an accurate result at the lowest fetal fraction? Okay, so it's like a myth, until these days. Frankly speaking, even we resist the use of the NIPT at will of the patients, none of the professional organization has issued the regulations yet, and it's not very easy to regulate because the companies can just go directly to their consumer. So nowadays, well, more than 50% of the time, NIPTs are done in the low risk individuals. So now that you have to deal with the result of the NIPT before the NT measurement, it is good to know that if you combine the NIPT and the NT, the thick NT is commonly an indication for the invasive testing. How thick is too thick? Many people are still fixated to the 3 or 3.5 millimeters. But actually, the more logical approach is that if the NT is over 1.9 multiple of the medians in that specific practice, then it will consider thick. So in this case, we have 1,400 subjects enrolled in the forecast trial, and in our center, and the 1.9 MOM actually came out as about 2.7 millimeters and not 3 millimeters. If the NIPT, if you look at individuals whom NIPT was offered as a primary test, you have to realize that if the result happens to be low risk, it does not negate the necessity of doing the NT scan. And actually, the first trimester is also a very good chance of doing the fetal anatomical assessment. Why is that? Well, we just have to take an advantage, for the fact that if the NIPT result happens to be there, okay, because the ultrasound alone, as a standalone tool, ultrasound actually has a very low detection rate of the atypical aneuploidies not detected by the NIPT. And actually, most of the major structural malformations are not really from the chromosome aberrations. So the modern day paradigm, would have been you do the dating scan at 8 weeks of gestation, and then you perform the NIPT at 10 to 12 weeks. If it were twins, it has to be at 12 weeks. And then if you get the result in NIPT back at 12 to 13 weeks, you do the first trimester scanning, and you combine the result of both of that, and you decide if the CVS or early amniocentesis will be needed. It's important to know that even the NIPT came out as low risk call, but the major structural malformations happen to be detected, on the 12 to 13 week scan. There is an 8% chance that you would have missed the common aneuploidies by the NIPT. So still, this case, you still need to go for the CVS or the amniocentesis. The follow-up scan will allow for a more confidence that you did not miss anything, especially for certain anomalies that has an option of the prenatal interventions like the myelomeningocele that can be detected on the second trimester scanning. It is also important to note that second trimester scanning will allow you to pick up the discordant gender from the cell-free DNA analysis and the ultrasound. If you see a different gender as per reported by the NIPT, compared to the scan, first of all, there might be a sample switching, there might be a wrong embryo transfer, so you should check with the lab. So actually, for the gender identification from the ultrasound, I use it as a to confirm the ID to make sure that we are examining the right patient. But if the gender discordant is really there and there's no sample switching, it could have been from the vanishing twins or the confined plasmamosaicism, and it will mean that the result in NIPT may not be so credible. Okay, so you have to go back to the primary risk of the patients and decide if she needs the invasive prenatal testing. If there is the sometimes the discordant gender identification from the ultrasound could have been from the disorder of the sexual differentiation. The most important thing that you have to pick up is the congenital adrenal hyperplasia, which is a female fetus with ambiguous genitalia, and this baby at the time of birth might suffer from a deadly salt-losing hypotension. So again, if you see the ambiguous genitalia in a female fetus detected from the NIPT, then it is good to put a red flag on the possibility of congenital adrenal hyperplasia salt-losing type. For the twins, the accuracy of all kinds of serum screening in twins will be down significantly, partly because there is a chance of vanishing twins and also the mix-up of the genetic materials, from each and every twins. But according to this picture, you can see that why 88-week scans might be better than just doing the first scanning at 12 weeks, because the vanishing twins, sometimes you cannot really see it very clearly at 12 weeks, but at 8 weeks, actually from my experience, is the best time for you to see the vanishing twins before it is gone. For the microdeletion, there is an upside of doing the microdeletion screening, because these anomalies like 22q11, they do not have the primary risk. It can occur to mother at any age. It has no specific prenatal ultrasound findings, like in the chromosome as well. But the thing is that the mental disabilities in the microdeletion and microduplications are not consistent as in Down syndrome. So, and PPV of the test are less than those of the typical aneuploidy. So it poses a very challenges in counseling. And if you do, tick more on the menu, there is a chance you will add a false positive, and to the examination. So the patient might end up, having unnecessary invasive procedures. So at times, if you don't do the targeted sequencing and you do the whole genome sequencing, from the maternal blood, there is a chance that you might not just pick up the fetal sequences, but you can also pick up aberrant sequences that were released, from the malignancies, and this can pose again a challenges in either you should or should not reveal this detection to the mother because she wasn't there apparently for this. So the take-home messages here is that the liberal use of NIPT in modern day practices may prompt us to change our practice in fetal scanning a bit. There is a shifting role of the NT as a point of care test in the modern day paradigm that many people would get the NIPT before they have the NT. So we just have to work around it so that we can still maintain the detection rate as well as the PPV on the population and the individual levels. We have shown you the importance to recognize the gender discordance between the NIPT and the ultrasound. It is important to note that there is a variability in legal atmosphere that will allow you for the determining of pregnancy, when the anomalies of the fetus are detected. So I want to thank everyone, for your kind attention.
Thank you for Dr. Tuangsit. So next, we will welcome Dr. Chonthicha Satirapot for giving us the talk entitled The Success Story of PGT-M with Thalassemia Disease in Ramathibodi Hospital. Let's welcome Dr. Chonthicha.
Thank you. Good afternoon, everyone. First of all, I would like to thank the organizing committee for inviting me to join this seminar. Also give me an opportunity to share my experience and my work. Today, I would like to talk with my work in the title of The Success Story of PGT-M with Thalassemia Disease in Ramathibodi Hospital. This is the outline I will talk in today. First, I will talk a little bit about the thalassemia and also the thalassemia situation in my country. And next is the Thai national policy to prevent thalassemia. And the highlight is the pre-implantation genetic testing monogenic disorder, or we call PGT-M. And the other word I feel familiar more than that word is the pre-implantation genetic diagnosis, or PGD. And final, I would like to share the PGT-M of thalassemia in my hospital in the process and molecular problem. As we know now, there are so many common genetic diseases in our world, but the thalassemia is the most common genetic disease in Southeast Asia. There are incidence or prevalence of carrier of thalassemia around 40% of general population in Southeast Asia. That means it's so big impact in our life. The clinical manifestation of the thalassemia, there are so many clinical manifestations, but in the severe type, I will let you know about two types. The first is the alpha-1 thalassemia. This have a big impact in our life of obstetrician because they make so many complications between the pregnancy in the fetus and also mother. We will face with the hemoglobin bad, high dot fetalis, and also sometimes in the mother develop the severe preeclampsia too. But the other type make the severe clinical too is the beta thalassemia major or beta thalassemia hemoglobin E. It's not make more complication between pregnancy, but it's make the patient have the severe anemia, and for the them life they will receive the blood transfusion for keep the hematocrit and also need the alkylating agent, and the life is long time the effect from thalassemia. And as we know, the thalassemia is the autosomal recessive transmission. in my country. We have the data show around 30 to 40% of population is the carrier of thalassemia. And the most common type of thalassemia in my country is the beta thalassemia, hemoglobin E. So also the treatment is only supportive with the blood transfusion or alkylating agent for the anemic patient. But the definite treatment is the stem cell transplantation. In my country, the stem cell transplantation can do in some center. That means all patients in thalassemia cannot go to this way. And also, if you can register for stem cell transplantation, the line is so long. The National Public Health, they announced the policy for prevent the thalassemia like this. First, in the people who plan to marry or plan to conceive, we let them know to screen the thalassemia for find the couple risk. And if we find the couple risk, we will let them know the genetic counseling. I will show later. And also in the pregnant woman, if she come to the antenatal care, usually we do the thalassemia screening for find the couple risk of thalassemia. If the pregnant woman is the couple risk, we will let them do the prenatal diagnosis. And also one of treatment of choice is termination of pregnancy if they're okay. This is the genetic counseling for reproductive option for couple risk of thalassemia. First as all, I will let them know the chance of fetal effect around 25% of pregnancy. Also, if they need to know the fetal effect or not, we will let them do the prenatal diagnosis. And also, the termination of pregnancy is the one choice if they acceptable to do. And another method is the PGT-M or PGT now is optional for the couple risk of thalassemia. And also, if they cannot do anything, living without children and also adoption maybe is the choice of reproductive option. Also, as we know, prenatal diagnosis, including the chorionic villi sampling or amniocentesis or chordocentesis, we can do but up to the gestational age of pregnancy. The benefit of this is the definite diagnosis in the fetus, and also we can give the treatment option for the diagnosis. However, the risk of prenatal diagnosis is the invasive technique, and also the couple will face to do the termination of pregnancy that make them feel not good. What is the PGT-M? PGT-M is the technique and process to prevent transmitting genetic disease before pregnancy. That means if we plan to do this, we have to do the assisted reproductive technology and also the fertilization technique. We used to do the ICSI technique. After that, if we get the embryo, we can find the technique to identify genetic defect in the embryo and transfer only free disease from or of embryo to the uterus. I begin my project, PGT-M project, in 2013 and 2016, and also received the grant from National Research Council of Thailand. In our study, I do the PGT-M in the rare disease and also in the common genetic disease. I select the thalassemia, especially beta thalassemia hemoglobin E, due to it's very common in my country. And also, if the some patients have to do the HLA match, I feel free to include this patient. After finish the project, I hope to develop the protocol for PGT-M in Ramathibodi Hospital. This is the process of our projects. First, we do the genetic counseling and also do the mutation testing and follow in this way. When we do the genetic counseling and mutation testing, we let the patient know the PGT-M and PGD, also postnatal test for confirm our diagnosis. Also, the patient will know the benefit from this test is we hope to increase the free disease in fetus and also decrease the possibility for termination of pregnancy. However, the risk of this project may be the patient will waste of time or cost, and maybe some patients they don't have embryo fit for transfer. Also, the genetic diagnosis in embryo, I usually use two methods, direct and indirect method for diagnosis. Also, they will give they will get around 5% of misdiagnosis from PGT-M test. And if they have the embryo to transfer, we can transfer only one embryo for embryo transfer each. This slide shows the conventional stimulation cycle. I did it in my project. First time, I will see the patient in day 2 or 3 of cycle and test the hormone level and did the transvaginal ultrasound. After that, we will go to start the recombinant FSH injected every day around 8 to 10 days and follow up with the transvaginal ultrasound, also hormone level. When we decide to oocyte pick up, that day we decide to do the fertilization with the ICSI technique. After that, we let them go to the day 5 of embryo we call blastocyst. In the blastocyst state, we do the biopsy and send the cell to the cytogenetic diagnosis. And also the embryo, all of the embryo was freeze all, waiting for the cytogenetic diagnosis. Also, the very carefully in this project is this step, the molecular genetic diagnosis due to very few cells. This is the problem of genetic testing from the embryo. As we know, when we test the blood for the DNA analysis, we get so many cells in blood sample. And when we purify the DNA, we can get around 5 to 10 microgram of purified DNA. That is more enough for DNA analysis. However, in the embryo, it's so different. Even blastocyst state, we can biopsy only 10 to 15 cells from each embryo. That means when we purify the DNA, it's not enough. We have only 6 to 7 picogram of DNA can purify for each. That means if we need to go to the DNA analysis, we have to do the whole genome amplification to increase the yield of DNA. But the problem of this is the too little DNA. Sometimes in some embryo, we cannot amplification. That means the embryo don't have the result, fail amplification. And also it's very important interpret for the allele dropout. The next step is I try to increase the accuracy of my diagnosis and also decrease the allele dropout rate. We used to do the molecular genetic special for this project. First, when we do the mutation testing, if possible, we usually do from the previous child if they have. But if don't have, we do in the mutation testing from the mother and father together. And after that, we use the short tandem repeated marker to relate with the embryo and father and mother. And finally, we use the linkage analysis to establish the disease-causing haplotype. After pass the special step, next is we can get the result and do the post-test genetic counseling again and decide to do the embryo transfer in frozen embryo transfer. If they get the pregnant, sure they have to do the prenatal testing again. This is a result of my project. I include 15 couples. All of this usually stimulate in 1 or 2 cycles, except this patient I will talk later. After this, we can conclude that success pregnancy with the live birth in our project is 8 newborn. And also the average stimulation protocol for each patient to success pregnancy is around 1.3 cycle, or can I see something like the 1 to 2 cycle stimulation is enough. Also, the accuracy rate from our project is confirmed by PND is 100%. This is show the, for example, when we talk with the patient, plan to transfer embryo. First is a free disease from thalassemia, and also normal embryo or euploid embryo. Sometimes, usually we can get 1 newborn per couple, but only one patient we can get the 1 monozygotic twin from embryo transfer, single embryo transfer. In our project can find 15 couple come to see us, and 22 cycle of stimulation, the mean age around 34-year-old, and we can get term normal newborn around 8 newborn, and also the unlindoped rate in our project around 3.89%. This is the special patient in my project. She come to ask me to do the thalassemia and HLA matching. She is 36-year-old, have already 3 children. All of them is the beta thalassemia hemoglobin E. All of this is still continuous but transfusion every month. That means her life is so terrible because her life is go to hospital at least 3 times per month for bring her children to do the blood transfusion. All of them is waiting for marrow transplantation registered already. I did the 4 cycle of stimulation. Each cycle I can get at least 10 oocytes. This is all of her data. We did in 4 cycles of stimulation and can get 61 oocytes, and develop the blastocyst for biopsy is 23 blastocysts. But only 1 embryo can fit for her condition, like the free disease and also match with the first child. But after I transfer this embryo to the uterus, she cannot get the pregnant. So try. But after finish the project, I can develop the PGT-M system in my unit already. This is the last one. Patient I do. She come to ask me at the end of 2020 for the thalassemia with HLA match. She is 34-year-old and previous child with the beta thalassemia hemoglobin E. And the second pregnant, she decided to termination of pregnancy around 20 weeks due to beta thalassemia hemoglobin E. And we start to talk with her and genetic counseling, everything in the end of 2020. After that, we start to stimulation. We can get 8 oocytes and 5 blastocysts for genetic diagnosis. After this is her result. You can see the 1 of wild type and 1 of affect disease and 3 of carrier. After we go to the HLA match, we have only 3 embryo left for transfer. Then I send the cell of embryo to do the euploid screening. This is the result. We have only 1 embryo can transfer due to euploid embryo. That means we do the embryo transfer. She can get the pregnant, and PND we confirm the result. Now she already delivered. She delivered with the cesarean section at gestational age around 31 weeks due to PPRM with previous cesarean section. Now the baby is so good and waiting for the next step. Finally, I would like to conclude this factor. The factor can interfere with the PGT-M result is the first is the whole genome amplification method. This is the very important because it helps us to have the DNA enough for interpret. And also the method for genetic diagnosis is the if we have to do the PGT-M, I suggest to do the at least two methods, direct and indirect method for help the interpretation result. And also the big one have the effect of our result is the embryo quality. All of them, it should be standardized and good. Is the result will be good. Finally, I would like to thank my team. I use so many people in this project. I would like to thank the T-cell team, stem cell team, and also the clinical team is the medical genetic and reproductive medicine. Thank you for your attention. Thank you.
Thank you, Dr. Chonthicha, for the wonderful talk and very exciting that we have healthy babies. So the last talk today is from Dr. Ming Chen. He is the Chef Medical Director of Changhua Christian Hospital. So he will talk about pre-implantation genetic testing today to us. Welcome, Dr. Chen.
Well, thank you for the organizing committee to invite me to talk. My talk today will be pre-implantation genetic testing, which is a bit overlapping with the previous speaker. In our genetic laboratory, actually, we have a few, or to be honest, almost all kinds of genetic genotyping tools in our laboratory in my institution. For example, we have the traditional karyotyping, and we have the fish. We have the multicolor and spectral karyotyping fish, and we also have the multicolor banding, which can stand all the banding of a specific chromosome with a fluorescent dye. And also we have some other kinds of genetic testing too, including array-CGH, MLPA, and real-time qPCR. For the chromosome microarray, there are two types of array, which one is the SMP array, another one is the oligonucleotide chromosome microarray. We are probably one of the very first few teams in the world to adopt this service into our prenatal genetic service back in 2008. And for the MLPA, the major advantage of it is it can amplify all the exons in one single PCR reactions. And for the real-time qPCR, which is more common, but it's also very powerful because I will show you later how we adopt it into our PGT or PGT-M service. In Taiwan, actually, one of the most common monogenic inherited disorder is also thalassemia, like the previous excellent speaker from Thailand. And in Taiwan, it's about 4% of the women or general population carrying the alpha thalassemia, which is the mutation spectrum of this disease is mainly large segment deletion, as you can see here. Also, actually, the most common type of mutation is called the Southeastern Asia type. Back in the 1980 or 1990, in my country, many pioneers actually established the nationwide genotyping program of this specific disorder because probably 3 decades ago, one of the most common preeclampsia cases were actually due to the alpha thalassemia major, which is the hydrophetalis caused by the hemoglobin bus disease. But after we adopt the nationwide thalassemia screening, then we generally tackle this. The next step is, like the previous speaker mentioned, we need to establish something in addition to gene therapy, which is at the moment still experimental. we need to devise something for the PGD to avoid transmission from this disorder generation to generation. And so according to the ESHRE, the international guideline, the PCR-based method remains to the gold standard. Just as you see in the previous speaker, they used a short and repeat linkage analysis, which we use also. And also the direct mutation detection. I would like to show you this specific case for the direct mutation detection. First, we have 3 sets of primers. 2 primers actually can amplify this part of the alpha globin gene cluster. Another set of primers will only be generate products if there is a deletion, because the large segment deletion will shorten the genomic distance between these 2 primers, so you can get PCR products. And that's why we can use this to identify the wild type, the carrier, as long as the major cases. And you can see one mutation type actually named by your great country, Thailand type. Also, we have Filipino type, Mediterranean type, and also a few recombination mutation type, or alpha or the hemoglobin Conte or constant spring, which is less common, but in our country we also encounter that. And this is the diagram for if we do the direct mutation detection by the method I mentioned above in the previous slide. You can see that actually the line 1 to 3, sample 1, is a major disease, is a major case. And the line 4 to 6 actually is a normal case. And the sample 3 is a major case. So this is about the direct mutation detection. And we published actually probably more than 10 publications in the past 15 years. One of the recent publications is that we use our patent protected in-house design mutation detection method using the neurodegenerative disorders. Because I also teach in National Taiwan University and a few universities in my country. So most of these cases are referred from many parts of my country. And I think it's common sense, because I think some of you may be interested. First, we use the duplex nested PCR to amplify the target amplicon we want to investigate it. Then we call the ARMS qPCR. Back in 20 years ago, I studied in Scotland. We used ARMS. ARMS means that if you have a point mutation in a specific gene or allele, then you design a primer. So if you have such a specific mutation, point mutation or small indel, then the primer will not anneal to the cases or the sample you are testing. But we adopt the qPCR to amplify the products. Therefore, you can easily differentiate between wild type, carrier, and affected patients. Just as the previous excellent speaker mentioned, that allele dropout is one of the major limitations of direct method. For example, in our series, we were very honest to report the false negative, because it's the autosomal dominant disease, which is much more risky. Because in autosomal dominant disease, if you mistake one allele, then the diagnosis will alter from normal to affected. For example, in this case, it's called the familial amyloidosis. In this case, we screen a few embryos and implant 2 of them. One of the embryo actually developed into the monozygotic twin. Another one, during our invasive confirmation, because I also do laboratory and also do invasive procedure, so I can do both. When I check the baby, actually, we found that one of it was false negative, which is caused by allele dropout. Therefore, I did the selective fetal reduction to ensure the birth of healthy monozygotic twin in this case. We also publish a review article invited by our national society, published in our national medical journal. And also we publish our, at that time, what was very new, because we actually tried to use the chromosome microarray and the next generation sequencing, as well as the qPCR, multiplex qPCR, to do the PGT-A. At that time, we called it PGS. And such these few papers are also among the first few from the world. So we actually did this field for many years. And one of the qPCR method is that it is cheap, it is robust, and it does not involve whole genome amplification. But because all the protocols in my laboratory are developed in-house, so we don't use some, commercialized platform made by the Illumina or Thermo Fisher or other service provider. We use our own method and their machines. So we are probably grow from development of this whole field. I would like to share with you one very eminent scholar from UK. Actually, he was the colleague of the Nobel laureate Edwards, Professor Peter Braudy. He once published a review, very nice review, talking that none of the current PGS methodology has been critically scrutinized by large randomized prospective trials. And he warned that it is not only important to select the best embryos, but there should be a trustworthy mechanism to select responsible physicians. Because I'm also a physician, I'm also a laboratory director, so I know the limitation and the difficult part of both sides. To be honest, we are driven by the need of our patients, but actually what we did or what we are doing or what we will do will genuinely affect or improve the outcome of our patients remains a question mark in this field. The major reason is a few. I think the previous speaker already mentioned them. Because I only have 20 minutes, so I need to make it quick. And for the comprehensive chromosome screening using for the PGT-A, about 1 decade ago, we used FISH. Still, sometimes we will still use it because for Robertsonian translocation cases, and for some cases, the embryo just don't proceed into the day 5 or day 6. The embryos just, after day 3, they stop grow. So in such specific cases, we preserve this technique using FISH to at least to do the pre-implantation genetic diagnosis of the Robertsonian translocation carriers, which is quite common. Actually, the instance is 1 in 500. And the other 3 genotyping platform we are using, including the chromosome microarray, qPCR, and next generation sequencing. And back in the 2007, a European team, actually by Dr. Mastenbroek, published a very controversial, and we call it now the Mastenbroek controversy, that the ideal rationale of PGS is try to reduce the chromosome abnormality rate of embryos to enhance the implantation rate and further enhance the live birth rate. But actually, when they review back the data, if you use FISH, even you use the 9-color FISH, which at that time was the most cutting-edge technology, actually the live birth in women with advanced maternal age is reduced rather than increased. So for a very long period of time, probably 5-10 years, a ferocious debate was made by the two sides. One side were support PGS, another side said PGS is not valid or not helpful to the patients. Let's see a very good thing from my friend, Dr. Joris Ramish from Belgium, the Catholic University of Louvain. From his team, actually, we did some study together. They found the remaining embryos of the young couple who achieved live birth after the in vitro fertilization and a significant proportion of the embryo actually were mosaic. From morphology, they look perfectly normal from embryology point of view. But actually, if you look at each blastomere of these embryos, you found that a significant, actually more than 60% or 70% of the excess embryos from 9 IVF patients are mosaic and structural aberrations. I think that poses a very serious concern for the validity of PGT-M. And in a study from a few years ago from another leading U.S. group called I think led by Dr. Richard Scott Jr. and Nathan Treff. They are terrific team. And from their reports, actually, they found that if you did PGS at day 3 cleavage stage embryo, then you have 39% relative reduction in the implantation rate. But if you did it in blastocyst stage, that means the day 5 or day 6, then the implantation is similar to the non-biopsy embryos. After this study, I think most IVF centers did their PGT at day 5 or day 6. And there was a time that a fresh embryo transfer was quite common and welcomed by a few doctors. So at that time, actually, we suffer from great stress because we need to produce the genotyping results of PGT overnight, which is very difficult actually, because in our law or in most countries in this world, actually the embryo cannot be stored alive after day 7. So I think this is at that time we suffer from huge stress to produce a reliable result. But later, because more and more studies claim that frozen embryo enjoy the same implantation rate and similar libus rate with the fresh embryo cycle, transfer cycle. Therefore, now our stress is reduced, at least from the time factor. And this is the argument made by another group, I think, from New York. They felt, well, the blastulation rate of embryo from day 1 embryo to blastocyst is only 47%. So if you calculate the cumulative libus rate, actually the non-PGS embryo transfer is superior to PGS blastocyst. So that poses a serious concern for the validity, or if we really can help these couples if we only do PGS. But I think as the previous excellent speaker, I think our consensus is if you want to do PGT-M, I mean PGD for monogenic disorders, then at the same time, I think it's justified to do the PGT-M. So you can do both. But if you only do PGT-M, then you need to be very careful if you really help your patients, or you are simply making money. Sorry, I'm very honest. My friends in my community or international know I'm a very honest person. Sometimes a little bit rude. We published our result actually back in probably this is 2016, 6 years ago. You can see the natural course of such embryo. This is a woman with is a carrier of ribosome translocation involving chromosome 14 and 21. And because we did the PGS or the PGD, then we found that we transferred some embryos and achieve a singleton pregnancy. But she then was offered cell-free DNA testing. Let me say that I don't recognize this type of practice, because I think the international standard is if you do PGD or PGS or PGT or M, whatever you say, then the gold standard is you do invasive procedure to confirm the diagnosis to avoid false negative. But actually, at that time, I think some of my friends, for example, the first speaker knows that time the NIPT was quite prevalent, or or compelling to most, both the women and clinicians. So she chose NIPT by another physician. But, at that time, the first time I thought we made a mistake because how come there is a trisomy 14? We have done the PGT. How come there is a trisomy 14 and exactly the one that involved in her ribosome translocation? But I did CVS. I also did amniocentesis and chondrocentesis, and in the end, because by serial follow-up and her autonomous will, she decided to follow my advice that it is very likely to be a case of confined placental mosaicism. So this case enjoyed a healthy live birth, and the chromosome after birth was completely normal. These are some mechanisms to explain how come this will happen. Actually, this is quite common in all the embryos of all mammals. But there's another very striking study published in 2015 from NEJM, a group, because such couples are often, when they seek cycles and cycles of PGT, no available embryos can be used. So they were very desperate, and at a certain point, some groups of researchers or clinicians decide to transfer the mosaic embryos, because we know that the embryo mosaicism is quite common in human embryos. So they transfer, for example, the first patient you can see here is a monosomy 4, monosomy 10, and the mosaicism percent was 40%. But in the end, when the baby was born, the karyotype was 46XX, which is completely normal. So after this report further, poses a serious concern if PGT-A really helps the patients. And another way to argue mosaicism is that mosaicism probably is not so prevalent. It's a technology used itself introduce false positive results. Also, you can see this nice study by the Richard Scott and Nathan Trepp's group. And they actually proposed the origin of the inconsistent results of biopsy. And also you can see there are a number of possibilities to cause this error. So only you can understand the correct evolution process or the nature history of human embryos, then you can interpret your results very precisely or more precisely, because we can never achieve 100% precisely. And in multiple biopsy studies, because some researchers claim that the aneuploidy probably has a preponderance or preference distribution in the trophetodon instead of the ICM, but actually a few studies later had proved that this hypothesis is wrong. So the clonal deletion, preferential allocations are both not very likely, but self-correction did occur and was observed in both the human and also the bovine embryos. Another study from Antonio Capabo's the group, they found that they actually summarized that the technical and biological source of T biopsy errors, and the first two still are the whole amplification error, because when you do the DNA amplification for further analysis, then you introduce some error inevitably. The question is the percentage. That means sometimes you introduce more, sometimes you introduce less. And because if you really, for example, I think the second excellent speaker also had a similar experience, because each experiment, especially involves such scanty amount of DNA, is prone to error. And sometimes we fail to amplify. And I also listened to her lecture. He also mentioned that in her thalassemia series, there are some cases to be fail to amplify. We experienced the similar situation also, because it's common to all laboratories. And for biological, I think there are some reason, for example, the reciprocal aneuploidy, which is quite common. Also, polyploid embryo, which is less common but still existent. And finally, this is, I think, something we can never solve in our PGT experiment. That means some euploid cell in S phase of the cell cycle, you will probably observe some specific duplication or numerical number disorder due to the S phase. So this is quite coherent and natural. So I think from the ESHRE guidelines, each experiment, the upper, the error rate of each methodology should be less than 5%. And for next generation sequencing, we had all the platform. We had Thermo Fisher platform. We had Illumina platform. We also have Oxford Nanopore, but it's mainly for microorganism, not for the PGT. But we have almost all the platform. And for example, the very sick, which is now very common and welcomed by a lot of IVF centers in the world, can predict as low as 17% of mosaicism. But on the other hand, 66% false positive rate needs to be aware of. So I think when you use the next generation sequencing, you get better resolution. But you introduce some artificial errors into the results. So in my clinic, I often was referred for interpreting some lab results from other laboratories. Sometimes it's quite bothering because the quality of the result is not very good. And this is something done by something else. So how can you, stand up or back up something you never did? So you just, because of the medical ethics, I just offer my advice. But sometimes, I'm not a very big fan of the NGS to be used in PGT. Despite I do have that, I use that sometimes, but I don't use it very often. And this is another study. That means because now we know that some mosaic embryos can achieve healthy libers. So they actually to look back into the data about if the mosaicism ratio is less than 50% or more than 50%. So it's quite intuitively, those with larger percentage of mosaicism will enjoy a lower libers rate or implantation rate or positive beta ICG rate. I think it's quite intuitive. It's not against our intuition. But all these data actually indicate whole chromosomal aneuploidy. Last year, when I guest edited a special issue for the Frontiers in Genetics, one group from Taiwan as well actually published a nice study about the segmental aneuploidy and the fate or the outcome of those embryos being transferred. But I think it's still an open question to the data or its implications in the clinical real setting. I also support some whole genome amplification is one of the major sources to introduce error, especially in such testing involve only very scanty amount of DNA. For example, this very nice study from Sweden, and you can see they compared Ampli-1 and Malbec. Malbec is a very nice kit devised by the Chinese American Professor Xie from Harvard. He then set up the Econ Genomics in Shanghai, China. But this kit actually, from my personal experience or from the experience of my friends across the world, is powerful, but its reproducibility is not very satisfactory. Because if you send it to the Econ Genomics, they can do it very well. But if you buy their kits and do it by yourself, then it's not very easy for you to get a very reliable result every time. I think probably there are some technical, secrets of these specific kits. So I think we also need to be very be aware of that, the limitation of each whole genome amplification WGA kits. In my laboratory, we actually have devised our own in-house, which may not be used by others because in each wet lab, we have our own laboratory condition, our different personal skill, and the experience also, the different, a lot of things will affect the in-house device of such a kit. But in my laboratory, we actually already established something. If you want to use the chromosome microarray for PGT, then you use a certain type of WGA kit. If you want to use the NGS, then you use another type of the WGA kit. And you want to do probably more than one or two or multiple gene alleles for the PGT-M, then we use another WGA kit if you want to use that. So I think in each laboratory, the directors and the colleagues need to devise their own protocol, suit their own laboratory, and get their own result to serve their patients well and suit the needs of their patients. And I think last year, December, we also published our series for the PGD using the hereditary hearing impairment, because it is also a very prevailing problem for the neonates, I think, across the world. So we also did something from our colleagues across this country. And this is the list of these cases. You can see most of them are caused by the connexin 26, which is called the GJB2, and some by OTOF, some by SLC 26A4, and some MITF. And because in the previous series, some of them using a direct diagnosis, but in our series, sometimes if we only find one allele in an autosomal recessive disorder, then we will do the haplotype linkage analysis, as the second speaker mentioned, that we use double method to try to achieve a correct diagnosis. I want to thank the invitation of the organizing committee and also our colleagues, and also thank National Taiwan University, Academia Sinica, and our Ministry of Science and Technology, and the medical college or university I teach. Thank you very much for your attention. Thank you.
Thank you for Dr. Ming Chen's wonderful talk. And before we start the panel discussion, I forgot to invite everyone to turn on the camera to take a group photo. So could you please turn on the camera, and then we will take a group photo as last time. And then we can start the panel discussion. Okay, you guys can see everyone, right? So
Yes.
Okay. Okay, so I think we received one question from the chat box, so I will start from that first, and I received a couple more. The first one was from, actually, Dr. Tuangsit has already answered this question. Is there technology can diagnose thalassemia in pregnant women like NIPT? So Dr. Tuangsit has already answered in the chat box. May I invite Dr. Chonthicha to add more based on Dr. Tuangsit's reply?
From my experience, I try to do that first, but it's so complicated. I have no idea to identify which one is the correct data. I try to do in 2 or 3 before in this project too. I try to do NIPT for thalassemia in the couple at my project is pregnant, but the result is so complicated. I and the genetic medicine try to fix off this problem, but I have no idea now. But I am not sure how to do that. No idea now. But let me. I think maybe we try to find another like the specific marker more than this, but it's the fragment of DNA, it looks so complicated for me.
Thank you. So let me invite Dr. Ming Chen to make more comments on this.
Well, thank you for the question. Actually, some of the leading group in this world already achieve monogenic disorders diagnosed by NIPT. I think Tom also already aware of that. But in reality, as the second speaker answer is not easy because the genotyping prevalent in each population are different. For example, the mutation spectrum or hotspots in Thailand or in Taiwan, probably a few. Some of the specific type we encounter more in this population, but in Greece or Turkey or Italy or Sardinia or Sicily, there are different mutation spectrum. So I think for a general panel to diagnose all thalassemia mutation based on invasive method can only be achieved by if someday we can capture the fetal cells instead of the fragmented DNA, which is underway by a few groups, including my own. So I think it's achievable, but it's not, a reality at the moment, and probably can be anticipated in next 2 or 3 years. But some groups may, be maybe run faster, so probably they will do something. But let me stress that something you read in the literature often are biased. It does not mean in reality you can do it. So I think this is my answer. Thank you.
Okay, thank you, Dr. Chen. How about Dr. Tuangsit? Do you want to say something?
I don't have any further comments.
Okay, thank you. So actually, we had one question left from last session. So from May 16th, I think
actually, instead of responding to the question, may I ask Professor Chen? You just mentioned about your work in progress on the fetal cells.
Yes.
What is the tissue source? You work from the maternal blood or the cervical mucus, or do you find it difficult to obtain the cells? And secondly, do you find the single cell PCR from the, well, not so fresh? It's like you biopsy the embryo. These are cells that have been shedding, into the system. Usually these cells are about to die already, right? So how do you find it easier or more difficult than doing the molecular genetic technologies, onto these cells?
Well, thank you, Tom, I'm very happy to see you. I think probably we don't see each other for a few years due to the pandemic, which is very lousy. Yeah. And I was very impressed by your many talks in the international arena. I'm sorry I didn't attend some of the organized, meeting you organized. I'm very sorry, but I'm very happy to see you. What you ask is a very professional question. And to be honest, there are two trains. I think you know it very well. One is to capture the trophoblast, which is, to be honest, very similar to the DNA-based method. Another one is the capturing the fetal nuclear RBC. But because many people claim they can do it, but in the end, it's very difficult because first the percentage of the fetal cell in the maternal circulation is very low. I mean the maternal circulation. I didn't do anything about the cervical mucus. I know some of the groups from the West actually did it. I didn't do that. I do the maternal circulation one. And we use a semiconductor chip and use the immunoaffinity, and we have a few publications. But I must admit to you that the throughput and the reliability is the major problem. And especially when you amplify, if the trophoblast is easier. So you can see the Danish group or the American group that did some progress for the trophoblast, but the fetal nuclear RBC, almost no people can do it. If by fish, yes. If by molecular, it's not very easy. For example, in my laboratory, we did DNA amplification for the fetal nuclear RBC. We found it is a very strange type of blood cells, or cell type. So it's not very easy to get DNA. We are still working on it. But for trophoblast, it's much easier. But I think in our sense, actually from the clinical view, if you can only amplify trophoblast, it means very little, significance to us, because the cell-free DNA already was originated from trophoblast. So how come you use a cell-based method unless you want to do the PGD? So I think for trophoblast DNA, you capture the trophoblast, then you amplify the DNA to do the non-invasive diagnosis of the monogenic disorder. It is achievable, but for the fetal nuclear RBC, I think it's much more difficult. Capture it is not very difficult, but to verify it, it is indeed from fetus, which is more difficult. But from scientific point of view, to capture fetal nuclear RBC is much more significant than if you only do trophoblast only. For example, something Arkady, which is based in Denmark, I think, what they did. But I'm not a big fan of their technology. We have our own technology, but the problem is, I think the throughput and also the reliability one, we already solved it. We will publish very soon. But I think in clinical real use, it still needs some time, because for the cell-free DNA, that needs to actually spend more than 10 years or to achieve that. So it is very reasonable for us to restart something already dead in 2002, because the NIPT study published by Diana Bianchi and a few of our friends actually already proved that the fetal cells in maternal circulation is a dead end. But because of the new technology emerged, now a few groups, including us, we can isolate and capture them. But the subsequent analysis is another story. Thank you.
So how? That's one more question. So what is your philosophy of excluding the possibility of carrying over of the fetal cells from previous pregnancy, or from the internal kind of hideout, like hideoutism, again from the previous pregnancies? How can you exclude that? I mean, it's not like the cell-free DNA that has a very, very short half-life. So when you see only one cell, how can you tell that, oh, this is from the current pregnancy, or is it carryover? I can never get the answer.
I know what you mean, Tom. This is a very good question. I think probably no people in this world can answer your question because of a few factors. Factor one, there are no reliable and everybody recognized platform to reliably isolate these cells. So someone claims they can, but how come they can prove that this is not from the previous pregnancy? And also, just like you said. So first we need to have something very stable, which is now we don't have consensus. The second one is that the validation. What you talk about is more than the validation and verification. And we are doing that. Of course, we can do the linkage studies, STR results, but even you capture, because we can do PGT, so we are very comfortable with if you have 5 cells or more, we can do a molecular diagnosis on that. But because our technology, actually the cells was attached to chips, so when you recover, it was already dead and fixed. This will reduce the quality of DNA amplification. That's the main problem. So what we thought before is if we can do directly lab on chip using the fluorescent the fish technology, and actually we have a technology we can stain each cells with a few times, and we can stain as more as 40 colors or 40 markers we want to check. So I think for at least for common micro deletion or trisomies, 40 is something enough. But for monogenic disorder, I think there are some way to go in the future. Thank you.
How about Dr. Chonthicha? Do you have any comments more on the 2 questions from Ajahn Tuangsit?
I think it's a very complicated procedure for the finder get more DNA and isolated only very few cell and correct cell from cell-free DNA. I have no idea. I try to do with the medical medicine, genetic medicine, but it's not work now. Let me ask about one question. If possible, is the medium culture in day 3 to day 5 for like the cell-free DNA or not? How about your
that's
opinion?
very good question. Thank you. Well, I'm not a big fan of so-called non-invasive PGT.
Okay.
That doesn't mean that their method is not founded or not good enough. But from my own experience, I don't see very reliable results when we did it. And because, to be honest, in this country, fetal sex determination is sort of illegal things.
Okay.
But in US or in some countries, I think it's legal. So if you only want to do fetal sex out of the culture media using a non-invasive method, I think it is achievable. But if you want to do something like, we did for each chromosome, every chromosomes, the numerical, or even, something only be detected by the chromosome microarray or NGS, it is not very reliable because we already tried that and we are not a big fans of it. We may be wrong because someone can do it, especially some commercial companies. But in our field, the most deadly problem for decades is that commercialized power infiltrate into the medical genetics in the teaching hospital and university, and it is a universal phenomenon across the world. So, every commercial company can say, we can do it, send samples to us. But in the end, when things go wrong, they just say, okay, they shrug their shoulder. Oh, we did mistake, sorry. So what? If you are from something, teaching hospital, you can do that. I think Tom and you can both agree with me. If we want to offer something to our patients, especially a prestigious institution, for example, the institution from both of you are very prestigious in your country, how come you can provide something unreliable to your patients simply due to the commercial propaganda? Thank you.
Thank you.
It's about the time. So let me thank for all the speakers and all the audience, and let me welcome Dr. Nina to give closing remarks as well. So this will be the end of our 2 sessions. So hopefully we will have more interactions in the future after maybe Taiwan open the borders. Will be very soon that you can see each other again. Okay, Dr. Nina.
Thank you, all 3 speakers. Thank you, our moderators today. This is a very good that interaction with Taiwan and Thailand speakers, particularly for the researchers. So I wish that in the future that we have more of the cooperation in research, or even like the exchange faculty, whatever. And as a moderator mentioned, maybe that's the September or the August, the border will be open in Taiwan. So we sincerely welcome the friends from Thailand to continue to visit Changhua Christian Hospital again. So thanks for your time. So then I wish you have good health and everything is fine. Thank you so much. Thank you.
Thank you.
Thank you.
Bye-bye.
Thank you, everyone. See you later.
See you. Bye-bye.
Bye-bye.